So we had to do a last minute makeshift. For some reason, we couldn't get the video up and working in the studio, quote studio. So we had to move over to this room, and Janice joined me. And thank you, Janice. I appreciate it. She did that because I pitched a fit last night. I was sort of like JT. JT says, look, locomotive. Here, JT made a comment. It's locomotive at the end of the tunnel. Doc, I'm kind of reaching my limit as far as my capacity to absorb bad news. I might have to go on an internet-free diet for a while. And you know what? That's what happened to me last night. I was about to go on a rant today about the failure to access test kits, because we really do need test kits right now. But let's just save that for a little bit later, and let's go back and actually talk about some very interesting and very neat things that are going on. If I can get the tech to work. JT, you asked for some good news. I just saw this in my inbox from Nature magazine. Coronavirus could have killed 40 million people if the world had not taken action. Really? Have we saved 39.6 million people already, or 39.9 million people already? The reality is, yes, we may have. Nature magazine's not, it's not a sensationalist magazine. It's perhaps the best science magazine in the world. Their numbers are really good. Now, if you start looking at the details on some of their articles, they're saying we already probably have saved tens of thousands, and again, maybe long term we'll save 40 million. And I think that's actually very, very realistic. So, so much for the temper tantrum I had last night and the rant I had planned today. There's a couple of different ways to look at this. And as is typical of preventive medicine, it's really hard to start quantifying what you've avoided, the damage you've avoided. So we will talk a little bit more, though, today about some of the things we've learned and the light at the end of the tunnel. And yes, you've heard that old joke, is the bad joke maybe, is the light at the end of the tunnel another train, a locomotive coming our way? I think there is some reality to that. I don't think that we have to suffer the mistakes that we've made before. I think there's some mistakes that we can recognize. We can start doing some things to prevent it. We know this is not the end of the world. We've made a lot of mistakes in terms of this pandemic. We've ignored advice. We don't have test kits ready. And for any of those of you who've actually seen the play Waiting for Godot, I was telling Janice last night, waiting for test kits is like waiting for Godot. We saw that play, 20 years ago. And that was 2.5, maybe 3 of the most boring times in my life. And that play is famous for being very boring and just sort of like a toothache. And it was written to be that way. But I won't go any further into that. We've got test kits that we're waiting for, PPE that we're waiting for, and tons of damage, lots of people dying as a result of failure to prepare better for that. But we've done some things right, and we've saved and will continue to save maybe tens of millions of lives. We're going to deal with COVID, but is there another train at the end of the tunnel? We'll cover some of this other information in just a minute, but Clyde, you want to go ahead and give us the intro real quick? No, we're seeing this right now, and we didn't see the water ball that came up. So this isn't the end of the world. Is it a 100-year pandemic? Could it be worse? Yeah, I think it is a 100-year pandemic. I think it clearly could have been far worse. We could have done like we did 100 years ago with the Spanish flu and not really latched on to the idea that we're having a pandemic. None of the countries that did locked down way too late. The public health officials have been waiting for this. We've got more on the way. And you know what? As a world, as a culture, as a society, as a species, we'll be better prepared for the next one. And we could have done a lot worse on this one. We still made a lot of mistakes. I mean, we had plenty of warnings, SARS, MERS, Chapter 13 of Michael Osterholm's book, Deadliest Enemy. It was all right there for us. And our preparation was inadequate. We didn't have masks. We didn't have, we threw a great healthcare team into battle with no protection. Vaccine research could have been a lot better. Social isolation plans could have been practiced. But you know what? We are where we are.
May I interject something?
Sure, please do.
Well, we also had the warning of China back in December, which was slowly released, but at least that data was available in January.
It was available in January, and what did we do with February?
And then the other remark I want to say is that there's an article about the CDC director, Dr. Robert Redfield, this morning, and the title is CDC Director on Models for the Months to Come. This virus is going to be with us. So we have not only what we may have missed in the past, but the data modeling for the future. And do you want me to mention a little bit about that?
Well, let me go through the intro in just a minute, and let's talk about that.
Okay.
What I was going to mention in the next couple of slides is we did have some warning. We had a warning starting back in January and December. What did we do with that warning? Well, we didn't. We could have made masks, gowns, and test kits in that 1 month. We frittered away February. Now it sounds like I'm criticizing.
And I think we sent our PPE to China, from what I've read, but that has to be verified.
Now it sounds like we're starting to wade into criticizing our leadership and our politicians. But as you and I discussed this morning, A, we're not going to do that. B, we were guilty too. I had multiple people ask me in multiple YouTube live events, other on-site events like at Kiowa, Doc, why don't you talk a little bit about the coronavirus? And my response was, well, number one, on a personal basis, we were focused on prepping for the Orlando event. So we said, we'll put it off until then. And my response then was, you know what? There are more deaths coming from cardiovascular disease right now. So that's why we're not focusing on coronavirus. So we did the same thing that everybody else did. We wasted February. So we made mistakes as a species. What do we tend to do? Speaking of what it sounded like we were going to go into, we blame somebody. We blame our leaders, then our leaders blame other leaders, and the blame game keeps going. But it's true. There's been a lot of bravery, a lot of innovation, and a lot of great people doing tireless work. Again, innovation. And when you think about our healthcare providers, they're going right into the jaws of coronavirus, a killer disease, knowing that people are going to come in with yet another wave of these and cough in their face, and they don't have the protection they need. Now, we've got a lot of good stuff going on. As we said before, you and I have talked about this so many times. We're just like everybody else. We're getting very sick of it, and then we have to get up and start talking about it again. You said the same thing that I've been saying. The biggest gap right now is what?
Testing.
It's testing. I mean, we keep talking about, and the things that we're using are healthy at home. We're in Kentucky, so our Kentucky governor's been ahead of the curve, and he's been using this term healthy at home. Our presidential leader, or our president, backed off on saying we're going to stop doing this 2 weeks from now, and just over the past 24 to 36 hours said, yeah, we need to extend this another 2 weeks. So we're all learning, we're using social isolation. Now we're realizing, no, that's not the right word. It's physical isolation. And as you were going to say, one of the things that you're seeing on the sidewalk when we go for a walk, people are now starting to take that physical isolation seriously.
Yeah, I think one of the points, I think the public health officials knew this ahead of the bureaucrats, and the people were waiting on the bureaucrats to make the decision, but they were still reluctant to start practicing it. And they still are. We've heard of COVID-19 parties. People are traveling with cheaper flights. I saw an article that the airways are still busy, but really people, it's a learning curve. People are learning. They're looking at these numbers every night provided by their governors or what they're reading on the news. And a week ago, I was complaining that when we walk in our neighborhood, that I myself, a 62-year-old woman with torn ankle ligaments, have to jump in the grass to avoid people. And I am just beginning to see the first signs that other people are moving off the sidewalk for physical distancing. So I do see behavioral changes in the public and people that were slow to come on board with what this epidemic meant.
And think about it.
Are now, waving the flag that this is real.
We have learned as a culture, as a society, how many billion people in this world? 300 million in the US and 10 billion in the world. Think of how much we've learned. All the individuals in the world have learned over the past few months about epidemic management, pandemic, this virus, how to keep it from happening.
Emergency preparedness.
And out of most of the people I know a lot more about how hard it is for people to learn something. You've got a doctorate in education. You spent years training as a health coach. And as you know, it's not easy to get people to learn health behavior.
No, it's not. And there's still a lot of temptations, what to participate in out there, but some of them have been taken away. Like here, the parks and recs are closed. We still have takeout food, but our non-essential businesses are closed. Now people are flocking to Home Depot and Lowe's to do their home renovation projects, but I'm estimating at some point more businesses will close. But there are other people that are making that decision before the government makes the decision for them. And they're taking it quite seriously. And we had our own learning curve, like you alluded to earlier. We were traveling in mid-February when this was going on. We were on a 3-week business trip. And after we completed our second conference, at that point we were in Orlando, as you mentioned, you said to me the night we finished that conference, maybe we should go home. And I was kind of surprised because you were the one that wanted to return to our original location in South Carolina for another week. And so we did make the decision to go home a week early. And then we made the decision, I shopped for groceries that next day. And then you came home and said, every 2 weeks. And, we don't have to go to all the details, but we've had our own personal decision making.
We've had a lot of debates, a lot of frustration. I would move ahead, then you would move ahead in specific areas. And we both have had a lot of pain and debates and anger in terms of learning what we've needed to learn to get where we need to be. So, yeah.
I don't think it was that bad. but I'm the germaphobe.
I didn't say it was that bad.
I'm the germaphobe, but you're the grocery shopping phobe.
She keeps telling me to wash my hands, and I keep telling her, eat what we've got here. Don't go into the grocery store. So there you go. So then the issue came up, and it continues to come up. And let me just go through a couple of slides here, if you don't mind. I personally think we need to wake up and smell the coffee about prediabetes. I covered this yesterday, and you see several headlines. You see several videos. We've covered a couple of videos about why coronavirus is more dangerous for diabetics. Clyde, why don't you give us just a minute or so of that video that we covered yesterday?
Which one, Doc?
The one about diabetes, the doctor in New York being so surprised. 24 of his 25 patients had diabetes or prediabetes.
1 second, Doc. I'll look for it.
Well, okay. Just tell me when you're ready, and we'll talk about it, and we can cover that.
Okay.
But while Clyde's looking for that clip, I've got to ask the question: are we missing something? The coronavirus deaths globally since the beginning have been 38,743. Plus a few more since I collected that information a couple of hours ago. Heart attacks and strokes, not globally, but just in the U.S. And not since the beginning, but just this week only, 30,000 deaths.
Deaths?
Yes. Now, think about it. Again, you've heard David Mintz say this many times. Every 2 weeks, we have a Vietnam War. And you go back and you're thinking, is that right? Well, yes. You look at the U.S. defense casualty system. They said there were 58,220 military casualties for the U.S. in the whole, what was it, more than a decade of that war. So we have a Vietnam War just in terms of our military every 2 weeks from cardiovascular disease, and we seem to think it's okay. Well, let's go back. As we know, civilians, a lot more Vietnamese civilians, mostly South Vietnamese, but North Vietnamese and other countries, other armies were involved. Total, it was more like, what, a couple of million? Well, even if it is, that's every 2 months, we still get another Vietnam War. And it's cardiovascular disease. And for some reason, that doesn't seem to get our attention. We've had more deaths from cardiovascular disease since the coronavirus broke out than we have from coronavirus. And I can say with confidence, we'll have more deaths from cardiovascular disease than from coronavirus. So what are we focusing on? Pangolins, cruises, treatments, supplements. We're focusing on vitamin C as a treatment, vitamin C as a supplement. We're focusing on whether Harvard is doing well with their FAQ, in our mass testing quandaries. But again, I do think there is another locomotive coming at the end of the tunnel, and it's the same one that we've been getting run over by and continue to ignore. It's diabetes and prediabetes. It is the epidemic. This is from CDC. This is our heart deaths, stroke death rates. There are some subtle differences, which I won't get into, but this is COVID death rates. Well, again, maybe we should be focusing a little bit more on what's causing, it's not so much whether you get infected with COVID, it's whether or not you get infected with the virus, the SARS-CoV-2 virus. It's whether or not you are susceptible to death. Kids have had, when you look at kids, they all tend to have some of the same things. And when you do x-rays of kids, their x-rays show the same thing, ground glass, meaning kids are all getting inflammation in their lungs too, but they're not dying from this virus. Others are.
I have the video ready, Doc.
Okay, and well, it's a good time to show it. Go ahead.
Actually, they are dying of the virus. There are statistics.
Dr. DU, actually 69 of the folks who have passed so far from COVID-19 were either diabetic or obese, which are both pretty common health conditions in Louisiana. To what degree should the average diabetic or the average person who is overweight be concerned by those numbers?
Well, I mean, I think that in general, it's a cause of concern for our population. You've been hearing a pretty consistent message from us that everybody has reason to be concerned and to take actions to protect themselves and their families from COVID-19. We unfortunately announced a death in a 17-year-old yesterday. I mean, we know that the people who are at the highest risk are the people who are in the older age group. But we also know that people with conditions like, as you're seeing, diabetes, kidney disease, and obesity are also at really high risk for bad outcomes. And so to the extent that you're somebody that has those conditions, we want you to take those steps to really stay at home, have somebody else do the shopping for you, limit your exposure to people who are sick, wash your hands frequently, all those things we've been saying. But even if you're not in those groups, we want you to do all those things for the loved ones around you that we know have those conditions. We want not only to not see as many hospital admissions, we want to see the rate of death decrease as well in the state. The only way we can do that is by taking these measures seriously. And thinking not only about our risk, but the risk to our family and the risk to our neighbors, as you've heard the governor say.
Just as a follow-up,
Thank you, Todd. So again, yes, last week I covered the CDC article about kids, and it showed that the kids, yes, there were kids dying, but there were kids that already had some other condition that was taking them down. So, and just like you heard on this past clip, the most common other condition that's taking people down is diabetes and prediabetes. And that didn't start with the COVID epidemic. So people say, well, okay, the CDC has only said, look, serious diabetes with complications. You're talking about prediabetes. Well, I am making that leap. And am I wrong in making that leap? I don't think so. You just heard it on, you heard it from New York yesterday. You're hearing it from the epicenter in New Orleans on this clip today. Again, prediabetes is part of it too. Prediabetes damages our tissue. We tend to think, well, I don't have to worry about my eyes until I have full-blown diabetes. My doc says I've got a little bit of sugar, so I'm okay. Well, the American Association of Clinical Endocrinologists says by the time we get a diagnosis of type 2 diabetes, a third of us already have eye damage. I personally have my first drusen right now, or druse. It's diabetic eye damage. And I've been managing my diabetes pre-diabetes very, very well. So we can all get really angry at the CDC because they maybe messed up test kits and they did this, they made that. But the CDC is right. Don't let the pre and prediabetes fool you. It's a very serious disease. It causes tissue damage. The other thing is, it's a lot more common than we think. We've been saying for a while, it's a third of American adults. And once you're age 60 or older, you're more likely to, you've got a significant risk of it, maybe up to a half. And here's the other thing. Only 1/10 of us know it. So we're burning our arteries, maybe up to half of us, and only 1/10 of us know it. Well, yes, actually the UCLA would say it's over half of us. And it's not starting at age 60, it's starting at age 30.
Which again brings down the age risk. Yeah.
So 30-year-olds are at risk because of prediabetes, and always have been, or have been more so. As the obesity epidemic grows, that clearly grows the problem with prediabetes. Now, how does prediabetes do that? Very, very simply, again, very quick run through this. We start off with nice clean arteries. As our blood sugar goes too high, stays too high, it burns that lining of our artery. If the lining of our artery is burned and inflamed, LDL, no matter what level of cholesterol is in your blood, it goes through that irritated, that inflamed lining. It won't go through the muscle layer, and so it gets stuck, and it continues to pile up until your immune system says, this shouldn't be here. Your immune system attacks it, turns it into a liquid, what we call hot plaque, and that begins to leak back out through that lining. This is an artery of a patient that died with a heart attack. is you see a whole lot of waxy plaque here. And here we have that hot, inflamed plaque. Here you can see it's liquid. It's retracted a little bit from the slide and very, very susceptible to break back through that lining, that intima layer. Here's another version, another post-mortem from a patient that died with a heart attack. Same thing. There's that intima layer. That was hot plaque, just like this, until it broke through the intima. And this is not hot plaque. This is part of the clot. The rest of the clot broke off, killed the patient. So we're burning our arteries. We have a lot of risk going on. We're doing a lot of good things. We're probably going to save tens of millions of people compared to what could have happened had we not done the lockdowns. And yes, I'm very comfortable we're going to get the test kits in that we need. We're going to start doing in large countries and other countries like the US and England what Singapore and South Korea have already done, flatten that curve. Are we going to lose a lot of people on the way? Yeah, there's no question. We've made a lot of mistakes. We're going to lose a lot of people, but we've done a lot of stuff right. But I still think there's another locomotive at the end of the tunnel, and it's diabetes and prediabetes, and I still think we're failing to recognize it.
Well, and in regards to COVID-19, CDC estimates 25% of the population has it and is asymptomatic. And without testing, we don't know that. So they're not quarantined. And then the epicenters, it's going to die down sooner in the epicenters, but in the states that have very little coronavirus, they're going to have a later peak, maybe even in May, June, or July. So it's probably not going to go away. I can say affirmatively, it's not going to go away by the end of April. It's going to be a long process.
Well, do you think anybody really thinks it's going to go away by April?
No, but like I said, with testing, we're going to identify there's this lack of knowledge right now due to lack of testing.
Yeah.
We're going to see a lot more numbers with testing.
Telling everybody to go stay in your home when everybody thinks, well, I don't think I have the virus. And you know what? I'm not going to get it. It's not really realistic, even for me yet. That's for something in New York and New Orleans. That's a blunt instrument. And as you said, it's very dependent upon people learning something that's still a little bit ethereal.
Right.
If you have a test and they get the test and they know that somebody else that they know is now infected and didn't know it,
right,
things start to become very real.
Very personal.
Very real, very personal. And then you can do things like South Korea and Singapore did. You can actually put apps on people's cell phone. You can find out, are you okay? Are you having any problems? Are you having any questions? You can actually track people. And this may sound like Big Brother, and some of the stuff they did does sound like Big Brother. Mm-hmm. They were tracking people using their cell phones. Are we going to go there? If we do in the US, there'll be a lot of people that push back and get very angry about that Big Brother tracking thing. But again, there's a lot more that we can do if we have the testing available.
Right. There's going to be a variety of peaks throughout the states. Time of peak. Washington State University came out with a model, I guess, of determining the peaks. And
I'm sorry, go ahead. Give us what you remember out of that.
Okay, so you've been showing, and we've been looking at in the news, the hockey sticks, the beginning of the virus, which is the increasing curve. And I don't know if you still have one of those.
I have one I can show. Hold on just a second. Well, no, go ahead and talk about it. I'll pull it up while we're here.
And so we're not seeing the completed bell curve, as a relative of mine pointed out to me when she sent me the Washington State University model. With that model, you can click on your state and see when your peak, where the data show your peak, when your peak will occur. And then you see a completed bell curve of that peak and when it starts dying down. And again, you know, that's going to change once the asymptomatics are identified with testing. But it is happening at different points in time, which again is the reason not to travel. And, you know, besides this, the physical distancing, you could be going into a state that's already at the upper level of this climb and then bringing it back to your state, you know, where you're much lower in terms of incidence. But that is the reason that the virus will probably keep coming up with different bell curves in different states through the summer.
So Clyde, are you able to see this graph with the hockey stick curve on it on the screen?
Yes, Doc.
Okay. So again, Janice, what you're talking about, first of all, I keep using the term hockey stick.
Does anybody else use that?
I don't know. So maybe we could explain what hockey stick is. It's right there.
Okay. Well, again, it's just looking at time on your horizontal axis. So in this graph, it starts in January 21st. You see 0, coronavirus. Is that globally, Ford?
Yeah, this is global. This is
Okay.
global cases for Hopkins.
So then we see a climb that starts out not immediately going straight up, but kind of a prolonged until about March, gradual climb. And then all of a sudden it goes up quite steeply in March.
Like a hockey stick.
Yeah.
So this is the long part of the hockey stick, and that's the short part of the hockey stick.
Yeah.
Now, you were talking just a second ago, though. You said it depends on which area of the world, which country, which state within the U.S. that you're talking about, that has its own hockey stick. Let me see if I can find an old coronavirus. Let me see.
So let me just give a for instance. For instance, in Delaware, the peak is April 14th, whereas according to the Washington State University model, whereas in Kentucky, it's May 1st, so 2 weeks later. And that's just in the United States, and there's states out west, I believe Montana is one of them, you know, that hasn't had a lot of COVID-19 identified in their population. You can look state to state and see when the peak is supposed to occur.
So maybe this helps us.
And that looks a little more like a hockey stick, I guess. The ones on the right.
So Clyde, can you see those 3 population curves there?
Yes, Doc, we can.
So we talk about, this was Spain, again, huge uptick. Italy, huge uptick. And if you go back in China in early February and January, the global, that's where the global epicenter was. The vast majority of the cases at that point. China was having a hockey stick. Korea hasn't.
And now we're the number one.
We meaning the U.S.
The United States.
Yes, I think we're driving the epidemic curve right now. So yeah, at some point, these epidemic curves are going to peak and then start coming back down.
Right. And it's going to happen over time. And as I mentioned, it's going to happen over time for different locations. Now, I'm going to ask you to enumerate why it is happening, even in the United States, over time. Is that?
What do you mean?
Well, okay, so some of the factors that would affect New York, with population size, the reasons that they're epicenters, New Orleans, New York, Detroit now, you know, why this data shows different bell curves, different peaks.
Well, I think we do know.
Travel.
We do know several things that were going on. With South Korea, South Korea South Korea got bit early with another coronavirus called SARS, and they were in the epidemic. They were the epicenter for the SARS outbreak. SARS was a coronavirus that happened before this one, and they took it seriously.
Emergency preparedness is another variable.
They were prepared. The minute that another coronavirus outbreak came up, their population, the people of South Korea, automatically went into memory of a more recent outbreak.
Right.
We didn't suffer that here in the United States, so we had a lot of learning we needed to do. Singapore, similar thing. They locked in immediately and understood what this meant. Why New York? Why New Orleans? I think you and I both have talked about that. New York's got a ton of travel.
Right.
Back when I was on the Maryland governor's task force for the AIDS epidemic, the HIV epidemic, the epidemics first started occurring, it was the people that were traveling. That was what was going on. Travel was creating it. Some of the earlier cases were being discovered in the U.S., and then you started seeing cases in South America, Central America, but there were cases among people that were wealthy enough to travel.
Right.
Same thing with New York. New York, major travel there.
And lack of emergency preparedness. So now the healthcare workers are being affected and transmitting as well.
Right. So let's go back and see if there's anybody there. Anybody listening? Anybody have any questions or comments? Let me see if I can find this now. I've been sort of jumping around. Here we are. Yeah, we've got, again, a lot of people. So Felix Cat, same here, JT, meaning a little bit worried about hearing more bad news. Duke Jason, thanks for contributing knowledge. Hey, Doc. Hi, sir. Again, lots of comments coming through. Again, as you can see, what happens is a little pressure builds up on that scrolling, and you click and it just pops a bunch of them up, and you don't know how many you're skipping. Kevin McCord, Dr. McCord from Cincinnati. Never ceases to amaze me how many people refuse seasonal flu vaccines, often with the most bizarre excuses, but run to the clinic at the first signs of an ordinary head cold and expect antibiotics. Kevin, you're not the only doc that I've talked to that is dealing with has been dealing with the flu epidemic over the past, each season, and sure enough, had a lot of people with the flu, and you, as well as many others, have said it's probably about 90% of the people that come in with the flu do say, "Yep, I didn't take the flu shot."
And I do want to point out that Dr. Redfield said that this is 3 times as contagious as the flu.
So Redfield is
director of the CDC.
The director of the CDC, who just came on over the past 24 hours and said, look.
He's had a low profile during this.
Right. SARS-CoV-2, this coronavirus pandemic, is going to be around for years. And anybody can take pot shots at anybody else and disagree with anybody else, but I think he's right. It is going to be around for years. Yesterday, I was telling our son Jeffrey, I said, the next 2 weeks are critical. They're the crunch weeks. And he said, that's what you said 2 weeks ago. But it is very true. As you start looking at these curves, here's what's happening. 2 weeks ago, everybody still thought we were a little bit crazy. Actually, go back 3 weeks ago, and everybody did think we were crazy. Our church was still having church services. People were making fun of you and me when you told them what I was saying. And it's a very different world now. Mm-hmm. It has been a major experience, a learning experience for all of us over the past 2 to 3 weeks. Well, guess what? That's going to happen the next 2 to 3 weeks, and maybe the next 6 weeks. Right. As we continue to go through this, we will get over it, but there's a major learning curve for all of us here. Jerry West, Germany's discussing plans to roll out the antibody tests and give certificates to people who can go back to work. That's a really good point. And I just have to cover this comment. Someone did about a page and a half set of comments telling why they think the antibody test is so important. I could not agree more. The antibody test is very important. And here are a couple of the reasons why, or one of the major reasons. We're going to start going back out at some point, coming back out of isolation. And as we do, as a society, as a species, that antibody test is going to be critical. But right now, when we're in the uptick of that hockey stick, what we need to know is not whether or not somebody's had it in the past. What we need to know is if somebody is infectious.
Right.
We're missing at least 2 weeks. It takes 2 to 3 weeks. It takes 2 weeks to form IgM antibody and 3 weeks to form IgG antibody. And that's what's been creating this uptick in New Orleans when they were having their parties.
Right.
Their what was the big party they had in New Orleans?
Mardi Gras.
In Mardi Gras, and the big parties on the beach in South Florida. We needed to know then who was infectious.
Right.
That is not the antibody test. That is the PCR. The
Protein.
No, it's not. It's not protein. It's actually looking at the DNA within the virus itself. So, getting into an argument about which test is more important, the viral DNA test, or RNA test, or the antibody test, is sort of like getting into a debate about what's more important on a car, steering or brakes. You need both. You really do.
Well, the next question alludes to that. The testing needs to be of both types. Do you have it, and did you have it? This gives the real picture.
Exactly right. Thank you very much, David Jones. I should have just read your comment, and maybe that would have saved us all a lot of time. Paul Lassa, hi guys. Do you have any thoughts regarding the peak in LA? In your opinions, how bad do you think it can get? I don't really have an opinion. I know a lot of people are talking about. They have been talking about LA being one of the next epicenters. Clearly, it's an epicenter of the population. You have any comments about it? Have you heard?
No. You can look it up on the Washington State University model and see what they predict. Again,
George Nakos, the problem with the world curve is the horizontal summation of all J curves. We need curves for each of our counties. Exactly right.
That's true.
Exactly right. You know, and because we don't have the testing available, we're not getting that right now. So that is what's, it's basic public health 101. In fact, we were talking about that. Those of you that saw the recent Bill Gates interview, and I know any figure you mention, there's going to be folks that want to hate on that person, but he was talking about quarantine.
Mm-hmm.
And quarant is based on the root word for, and it was based quarter or 40 days, and that went back to the Black Death, where they would keep a ship out in the harbor, not let them come in for 40 days, with the hopeful public health assumption that keeping them out there for 40 days was going to burn out whatever transmission of Black Death was going on. And it's interesting, we're still
and that's when they're symptomatic, correct?
Well, that was any time the ship came into port.
Okay.
Depending on the port that you're talking about.
But we are shedding virus for 48 hours before symptoms.
And shedding virus for how many days before the antibody test, before we show antibody, like a week or more.
Yeah.
So again, basic public health history, look for disease, case find. When you find cases, when you find transmission, isolate it, quarantine. And we're not able to do that with a blunt instrument of just hopefully tell everybody to voluntarily stay at home, or even if you're more of a control-oriented government like China just do the lockdown. Yes, those help, but they're too blunt of an instrument. They do not allow us to do case finding. So, I'm in Milford, Delaware. Farouk Farr. Farouk is a medical person in Iran. He gave us some warning about kids getting killed with this virus. The experience shows staying home will flatten the curve for a short time. The only way is to isolate. And again, the system just jumped over a lot of comments. Sorry about those that we skipped. James Cantor, I noticed I've been eating more carbohydrates this week from stress of COVID. I'm walking more. Yeah, I'm doing a little stress eating too. You were. Go ahead. There she goes.
When we went to Louisville yesterday, he had to comment on every fast food place that we passed, and even bourbon chocolate store that we passed. I finally took a video of it.
we went by what is it, that Butterburger? Culver's, and I was thinking, man, it'd be so. I don't eat a lot of that kind of stuff, but it just looked so good. A caramel salted caramel cement mixer. And then there was a big Johnny Rockets advertisement with a picture of a giant bacon cheeseburger. And it's like, I was okay till we went out.
Yeah, but that's a real thing that you are mentioning, James, that we're around I mentioned this maybe yesterday through a comment, when we are quarantined, we're around our fridges. So it is very tempting to go to the fridge, whereas at work you might not have that constant ability to have access to food. So that is a very real thing. And as Ford talked about earlier with the prediabetes, we do need to look at our carb intake based on, and I'll say personalized data. If we could test ourselves for prediabetes with a Freestyle Light, which is a finger stick, and look at how our carb intake affects our blood sugar data. So it's a very real thing. And, and anxiety leads to eating, as you mentioned.
Or habits, or boredom.
Right.
So again, personally, I was okay. It's sort of like an addict. Addicts are okay until the addiction material is in front of them. Then they really start getting. Yeah. If you look at research, I mean, that's when they really start getting problems.
Jittery.
I got jittery
and I was just like, I had no attraction to any of these fast food places. It was interesting looking at it from the outside.
And I eat very, very little fast food. And I used to travel a lot, and when I'd go to McDonald's, sometimes that was the only place you could go. I discovered that you can eat salads and grilled chicken at McDonald's and have not such a bad meal.
And we're getting
looking
sick
at
of
those pictures.
Yeah,
and I'm eating nothing but stuff here. I mean,
and if you're curtailing your grocery trips, as we're going on 3 weeks without a trip to the grocery, you don't have a lot of choices left. And again, I don't have the same family history with food as Ford does, but it makes you, I've thought about a steak at a good restaurant that I like. I'm not thinking about fast food. You think of food when you're kind of experiencing a shortage if you are in fact isolating.
Yep. A couple of other questions. I don't know if this is Jesus Life or Jesus Life. It's any update on hydroxychloroquine. And the Swiss company that donated millions, FDA approval for use in serious cases. I think the FDA is fine with docs using it in serious cases. I think the pushback has been using it for prevention. Then there's David Murphy's. David's got a couple of questions about irrigating your sinuses with a 3% saline solution. He brought up a video by Bradley Bale who addressed this, and then he's saying Brad Bale is the author of Beat the Heart Attack Gene. You ever heard of Brad Bale?
Yes.
Brad was in our practice when we were in Nashville, Tennessee. Brad's a great guy. I learned a heck of a lot from Brad, and I do respect him quite a bit. Regarding, he and Amy have done major work in terms of getting the providers around the country. I mean, this is a couple of decades worth of that yeoman's tour of teaching physicians, dentists, PAs, nurse practitioners about cardiovascular prevention and the true causes of heart attack and stroke. I saw one of our folks, Joe Riley, sent me a text on that, and Joe, I apologize for not responding. I really didn't know how, because I do respect Brad and his research quite a bit. And Brad's video, I think the one that Dave Murphy is mentioning here, it talks about hypochlorous acid. And yes, there's no question this virus is very susceptible to hypochlorous acid. Now, is it really created in a big way from snorting it, saline solution? I haven't seen a lot of evidence on that. And here's the bigger issue. It's sort of like people saying, look, if you order food from outside and it comes in and it's been prepared by one of the restaurant cooks that had COVID infection and didn't know it, aren't you okay? Because isn't your stomach gonna kill it, your stomach acid? I don't think either of those are assurance of safety. I don't think nasal irrigation with salt, like Brad's mentioning, or eating takeout food, we talked about that a couple of times, are really assurances of safety. And why? It's because you look at the anatomy of your gastrointestinal tract and your upper respiratory tract. There's a reason that it's called oropharynx. Oro means mouth, pharynx means the area behind the mouth where you breathe. The GI tract and the upper respiratory tract mix. So you're going to get it in both places, no matter which way you ingest it, whether you breathe it in or whether you eat it. And I just don't think that we're going to get proper safety by
treating a localized area.
Yes. So I'll just say, leave it at that. Joseph Page, notice that some people feel it's fine to visit family members not showing symptoms, but live in different households. You see that a lot. In fact, here in Kentucky, one of the major problems that they've had is people having family congregations out in local or state parks. And they've had to shut a few parks down because people were just congregating there. They think that if you know the other person, it's okay to congregate them with them because they don't have the infection, because they don't have symptoms, because we don't have testing. Waiting for Godot, waiting for the test kit.
Yeah.
147 degrees west. Very smart lady. Lots of good comments. Up in Alaska, March 8th, they had a concert in a coffee shop in Michigan in a college area. The performer tested positive a few days later. Now Michigan has a big problem. Well, again, we're right here in Kentucky, and one of our transmission events made the national news. It was a coronavirus party. And somebody got the infection. It appears to have been transmitted at the coronavirus party. Dennis Williamson, who can best confirm we are no longer contagious? For instance, China used a two-test method and simply released former contaminated vectors or patients without checking. Not sure that I actually understand. Do you understand what he's saying? I think we're all saying that the antibody test is going to become a major tool when that time comes. But I don't really, there seems to be some detail in that question that I'm not.
I guess it's the going back to work that they're doing in China. For people that
Well, I know that. Well, do you want to speak to that?
No.
Okay. Fire Garden, thoughts on officials distributing N95 masks to the public in the interim for office workers and mass transit users. Again, major debate around that. if you look at cultures, several cultures in the Orient, the U.S., Japan and China specifically, as well as some others, have always, for decades, used masks. In the Western countries, you don't see so much of that. Now, there was a cardiologist that started doing some deeper look at use of masks he went into his hospital and noticed so many healthcare workers that didn't have masks and were walking around the hospital without them, and concerned about how many of them were breathing and exhaling coronavirus. He actually made a pretty good case that we should probably, in the West, reconsider that custom of not using masks. Whether he's right or not, I think remains to be seen. Here's the other side of that debate. At a time when we don't have enough, when we're putting the healthcare workers into harm's way, throwing them into a battle and killing them, and they're dying because they're infected with coronavirus because they have inadequate protection, I would agree with the other side of that debate that, look, you know what? Let's make sure we protect our healthcare workers who are standing in the ER waiting for the next COVID patient to come sneeze on them before we start doing these routinely in office workers.
Well, and our healthcare workers are emergency personnel and are yet not to be named emergency personnel, the grocery workers that are essential.
Our son is a grocery worker.
So I think we have to get the personal protective equipment to those people first.
Kevin McCord, what's your evaluation of the state epidemiological data for our home state of Kentucky? Given the lack of testing available, it seems like prevalence is significantly underreported. There's no question about that. Here, the real question right now is, for every case that you have, is there a dozen unreported cases that are out infecting others, or is there 100? And I think it totally depends on where you are in terms of that epidemic curve. Are you in the early part of that hockey stick? Are you right before that hockey stick? Or are you getting close to the top? And I think that really determines what that number is. How many how many unreported are out there transmitting the disease to others? And for those people, is the R naught the reproductive index? Is it 3? Is it 7? Is it 1 or less than 1? How many cases in Kentucky? You're the one that keeps up on that. Wasn't it a couple of hundred?
It's over 300.
Yeah.
I don't know. I didn't see the data yesterday.
So if there's if there's 10 and if there's 10 per reported case out there transmitting the disease, that would mean there would be 3,000 people in Kentucky transmitting it to, let's say 3. So that would be 9,000. And let's say that that transmission time was 3 days. So in 3 more days, there would be 3,000 up to 9,000. In 6 more days, then it would be 27,000. So yeah, it's a great question, and I think Kentucky's very early in the hockey stick for our curve. Dennis Williamson, checking their feces, they might have discovered that their feces still had virus 19 days after 2 negative tests. Perhaps this is the wrong venue. Again, I'm not. Good points. A lot of it it is shed. The virus is shed in a big way in feces. And again, I think I don't understand what you're saying about the actual testing that was being used. James Cantor, Fire Garden, they need the N95 for healthcare workers. That's exactly what we were saying, James. Paul Lassa, thank you for the valuable resource, Dr. Brewer. I just found U of Washington's state-by-state projections. Very, very interesting. Well, Paul, I would love to say you're very welcome and take credit for that, but that was Janice.
And that was my sister, actually, in Delaware.
Her sister's
found the article.
Her sister's a big reader. So yes, it is a great resource. Jeff Madrak, virus numbers from Italy are extremely suspect. tagging anyone who tested positive but died of other, often multiple comorbidities with COVID-19 as cause of death. Yes, I'm familiar with that debate. And do you want to go into that debate? The whole debate where they're saying, look, these people would have or probably did die of something else.
No.
I don't want to go in that debate either. That's a whole different set of debates where, they say fools rush in where angels fear to tread, and I've rushed into a whole lot of places. I know I am a fool, but I'm not going to rush into that one. Tim Verwick, what are you doing traveling in Kentucky?
I mentioned visiting our son. We met him at a empty outlet center.
Yeah, okay.
Where we walked more than 6 feet apart. And we checked in with security to tell them what we were doing before we started that, to tell them how we were going to practice physical distancing.
Thank you very much, Tim, for bringing that up. Yes, we stayed in the car. We did not stop at a gas station. We did not stop at any place where there was public. We met our son and walked in a parking lot and stayed 6 feet away from our son. You don't need to take it back to Lexington. Okay, well, we don't think we did. We need worldwide standardized rules for determining actual cause of death. Otherwise, these statistics are pretty unreliable. Well, any set of statistics and that's part of public health and epidemic management. You have to figure out, okay, what statistics work and which ones don't. And there is no such thing as a perfect set of statistics. Any comments on that?
No.
Quarantina Itaf. You know what that is?
Quarantine, Italy. Or I think that's what, it's in a different language. But.
Oh, okay. Date of PrevMed Orlando is February 28th. Date of Mardi Gras in New Orleans, February 25th. Very good point. Any comments about that? So you're saying, look, we did our own part in terms of making mistakes.
You know what? I totally agree, because I will admit we shook hands with people from all over the country, and we were supposed to do another conference in March or in April before it was canceled, and I said I'm going to make an announcement.
We shook hands, and I don't remember that.
Yeah. We did.
We're as bad as some of the public.
And that's why New Orleans says,
figures.
Don't Mardi Gras shame us. People are doing this individually, groups. We see our officials having COVID-19 from dinners that they've had together. So I don't know that shaming is worthwhile. And that's what, New Orleans has said that. Although Mardi Gras is a huge party, much bigger than the 26 people that attended our event. But
I thought you were talking about an event after Mardi Gras in New Orleans that was a big deal.
No.
Okay.
They canceled St. Patrick's Day.
Oh, okay.
But people were still out.
But anyhow, 909 NOLA, and for those of you who don't know, NOLA is New Orleans, Louisiana. That's what I'm guessing. And
I didn't realize that was from New Orleans.
Yeah. Very good. Thank you very much for
it is kind of this, what
out.
we didn't know. And that's the same thing for Mardi Gras in New Orleans. Our country was still in denial, I think, of the virus. And we were too on that date.
We were definitely in denial as of February 28th. There's no question. We wasted the whole month in terms of opportunities for managing and our potential contribution to the coronavirus pandemic. John Davy, a quarantine attack is Italian for 40 days, entered the English in 1650s.
Oh, that was the previous comment.
Yeah, Quarantina. He was saying, yeah. 147 degrees west. They still have people in quarantine in Wuhan. Vast majority is 20 days. Can inhalation drug like masks? I agree that healthcare workers need masks, but you can make them from t-shirts, vacuum cleaner bags. Yeah, there's been a heck of a lot of innovation that's gone on the face shields as well as the face masks. And again, we've got several we still have some activities going on with that testing program that I've discussed a few times. One of those activities is involving several different groups actually buying Tyvek material, the house wrap material, from Lowe's and other hardware stores and taking it to cottage industry, small Kentucky-based seamstress companies, and they're making those gowns out of Tyvek house wrap. Dave Murphy gave us of what? Oh, was that a $5 contribution? Thank you again. Somebody started that yesterday, and we appreciate that so much. We've got, again, for the most part, we're supporting this out of the heart attack and stroke prevention, as well as these COVID educational activities, out of our retirement. Janice gets a little bit nervous about that. We've kept our costs to a minimum, but now we have a few families that we're supporting with this. So any contributions that we do get,
here's another.
So any contributions we do get go right back into making this kind of information available for those of you that are interested. Thank you again, Dave. I appreciate it. I think what they said yesterday is you go to the right down under comments, and there's a place where you can do those contributions. And it was Patreon, by the way. Patreon. We do have a Patreon account. I don't remember if it's Ford Brewer or PrevMed, but look up those keywords if you'd like to. And if you'd like to support our activities, if you'd like to support the channel, if you'd like to support this focus on education for prediabetes, heart attack, stroke, and the real killer pandemic that's going on right now. Were you going to say something about this one?
No, the next one about the quarantine.
Okay, so Kevin Sullivan, good to hear from you, Dave. Kevin, would love to assess the strength of my immune system. What are the biomarkers, if any? Seems those with cardiovascular disease did fine, except if the virus injured their heart. Was the immune system the key difference? Yeah, you see a whole lot of comments about the immune system, and that is the real differentiator here. You hear a lot of people commenting and frustrated that we talk about transmission, we talk about treatment, but we don't talk about the real differentiator here, the difference between the 10-year-olds that get ground glass, inflammation in their lungs but don't get a problem, and the other people is the immune system and the state of the immune system and what prediabetes does to the immune system. Now, do we have good biomarkers for that? There are a ton of biomarkers for immune system function, things like IL-6, and Janice is going to start rolling her eyes because I'll get very geeky. The bottom line, though, is that we really don't have a good handle on that yet. Was this the one you were going to make a comment about?
No, I just thought he wrote back. It was interesting.
Oh, 147 degrees to 99 New Orleans, Louisiana. I was just out of first quarantine during Mardi Gras. So this is, I think the name is Gavril. As you see, that looks like Cyrillic script or something. He's in the Kiev in the Ukraine. Gavril here. Oh, it is Gavril. I remembered your name. Thank you for joining in the comment. We're going to conquer this. I'm feeling very confident. Greetings to you and your lovely wife. Just like me, you really married up. You know what he means by that, right?
Well, and I think based on that comment, we tend to focus on the negativity with the virus and, what we're missing without testing, the lack of personal protective equipment. But as we started this meeting today, we have had, even us personally, an intense level of learning about this virus. And we are making choices now that we were not making back in January and halfway through February. And that's what I'm seeing in the public as well. So I think there is some positivity of how much we've learned, how much this is going to change our preparedness in the future for other pandemics, preparing our emergency personnel, healthcare workers to deal with this. So I do, in spite of all the negatives, and I know several people have commented, it's hard for me to watch yet another COVID-19 video or news source. There are definitely things that are going to change how we do healthcare and prepare for this in the future.
Definitely. I keep, me, I'll accept blame, then I'll start stewing over it, and then go back and start. And I go back to 99 Nola's comments about the when Mardi Gras was versus our event on the 28th. And I keep thinking, on the one hand, there's, do we want to stop dealing with the prediabetes epidemic? And the answer is no. I mean, for reasons that I covered before.
Yeah.
But that still doesn't get me off the hook. It's not an excuse for ignoring COVID-19, which is what we did because we were focused on that event.
Right.
You can do both. You should do both. And we're learning, just like you're saying. We're learning how to manage things. Just a few other comments, and I think it's time to move on and give everybody a break. Joseph Page, what are the 2 negative tests looking for to declare you as not able to transfer the virus to others? So again, we've gone back and forth on that several times. I think what people are referring to is there are 2 types of tests. One is PCR, polymerase chain reaction. You don't need to remember those terms. It's looking at the RNA, the genetic material of the virus itself. So that's how we know to look if there's the virus inside the oropharynx when you swab it. And we used to think we had to jab the swab. Someone else had to jab the swab all the way back. What we found just over the past weekend is that you get almost as good results. In fact, maybe as good results for the individual themselves to just put the virus up. To put the swab up here. That's looking for the genetic material of the coronavirus in the nose or the throat. The other test is looking for the antibodies that your body makes. So, Joseph, I think that's what that reference is, 2 negative tests, no antibody and no transmission. At that point, you still could have, both of those could be false positives. And you mentioned that earlier. How could that happen?
I don't remember.
Okay, so there's a thing called incubation period. That's the time from the
asymptomatics.
time that,
The
yeah.
asymptomatics.
There's what? You
You're
get
not
infected
shedding-
today.
You're not shedding the virus yet.
You get infected today. You at days 1 to 3, maybe you're going. At 3, you're going to maybe test positive on the virus test, and then it's not until day 14 or more that you're going to test positive on the antibody test. But days 1 to 3, you can still get both of those tests as negative. So very good point. Thank you for bringing it up. 6 virus related case in a 20-year-old female. Last comment, unless you want to cover other ones. Jackie Shaheen, you asked about epigenetics, John Tocho. Mark Harris, ND, MD, PhD, brilliant researcher in that subject. He had his PhDs by age 12. I think he is COMTUT area. Well, don't know what they had to do. Oh, wait a minute. Another 99 NOLA. Thank you very much. $20. No judgments. Appreciate your honest reflections. And we appreciate your contribution, and we certainly appreciate the town you live in. I don't think we mentioned that.
We both started out at Charity Hospital in the 1980s. So I read actually NOLA.com every day.
I interned at Charity Hospital, the big free in New Orleans. Our daughter went to she was there, so we were able to go back a couple of times over the past couple of years. She trained in public health at Tulane. So big focus for us. Some of the most fun time we had in our lives was our early adult life in New Orleans. And that's about as far as we're going to go on that story. Thank you so much for your interest.
And please mention that he contributed.
Oh,
At Sonola, just contributed $20.
yeah, that's what I say.
Oh,
Thank you again for your interest and your contributions helping to support the channel. Greg Clopton. Greg just contributed $20. Thank you so much, Greg. We appreciate. Again, the $20 is a big deal, especially, you know, we outsource or offshore a lot of our video editing, a lot of, you know, for example, Clyde's working with us from the Philippines today, and $20 in the US, it's a big deal. It is a very big deal when you're starting to talk about some of the Filipino economy and some of the contribution that those bucks make in terms of getting that information out. Thank you again so much, Greg and 909 and Enola. Talk to you later.